Okay, so for some pre physical therapy, or before we do the Therax or anything like that, whether it's passive range of motion, active assist, or active range of motion, I like to always target the scapula, get that scapula moving, because the arm has been in a sling for so long. No matter what the point is, we want to get that scapular mobility going to increase the glenohumeral scapulo synergy. So I want you to scoot towards me just a little bit. And for this, I generally just take the patient's arm. Well, right here it'll be fine. Depending on what the restrictions are, it's important to have it within those. So I'll take the patient's arm, whether it's fine resting next to them or in my armpit, and I proceed to do all different directions, not going into pain, just allowing some upward rotation, some downward rotation, and some protraction if able, some depression, and going through those. And then I'll have you roll on your back. And then, see if I can stay out of the way for this video. Scoot towards the side of the table. Then I like to go into glenohumeral posterior mobilization. So slight distraction right on that joint line. And just getting in and kind of loosening up the tissue. You don't want to go into pain by any means, because if you ruin this, the surgeon's probably going to be pissed, having to go in and re-repair it. And then I go into some just passive range of motion. They're probably not going to be up that high, so I'll just go within the available range. I'll do some abduction, but generally you're going to have the guideline of no higher than whatever it is, 50 degrees, or later stages no higher than 90 degrees. And then internal rotation, and then external rotation up until that restriction, and just going to the end, and just maintaining mobility there, maintaining the tissue stretch there. And then I prefer to do those and any soft tissue mobilization as necessary for pain. I don't like to use ultrasound just because I don't like some of the evidence behind it, and I feel like using my hands works a little bit better. And then moving into the actual therapeutic exercise after the mobility is, or the shoulder is, quote, loosened up a little bit. So active assist with a dowel or anything of that sort.